This unit discusses the sources of violence in healthcare organizations. International and national organizations, as well as provincial authorities such as Alberta Health Services, agree that sources of violence include not only patients and their family members or support persons, but also members of the public, workplace colleagues, and supervisors and managers. Patient aggression, and to some extent, aggression from their family members, is most often studied. Intimate partners within or outside the workplace are another, albeit infrequent, source of violence in workplaces. As we know, this violence is more commonly, though not exclusively, perpetrated against women, who are the greatest proportion of the healthcare workforce. Violence at the hands of colleagues and supervisors or managers, referred to as horizontal and vertical violence, is becoming more commonly reported and researched, particularly in the nursing literature. Interviews conducted with 8 key informants for the preparation of this module confirmed that it is in fact more common in their experience than patient visitor violence. Horizontal and vertical violence is more likely to be psychological in nature, for example, bullying or sabotaging success in the workplace. Measures discussed in this module will help occupational therapists and students to protect themselves from violence emanating from each of these sources. By far the most available information about workplace violence relates to violence initiated by patients, clients, or their visitors or support persons. According to a study by Whittington et al., nurses were physically assaulted, threatened, and verbally abused by patient, relatives, or visitors at higher rates than all other professionals. Patient visitor violence was reported by 57% of nurses combined, 17% of physical therapists, and 10% of occupational therapists. Verbal violence was reported more frequently than physical violence, which was in turn more prevalent than receiving threats. This 1996 study, which included a small sample of OTs and PTs, is a bit dated and was conducted in a general hospital setting. However, this trend tends to persist in more recent studies in all types of practice settings. A smaller Canadian study, published in 2012, examined patient client initiated violence in occupational therapy settings specifically. Durkatz found that 4.3% of occupational therapy respondents reported injuries from acts of patient violence. However, in another part of the study, another 8% of OTs described being hit with objects, punched, bitten, and stabbed and spat on. Interestingly, they did not label these as acts of violence. If they had, the rate of violence would have increased to over 12%. One therapist stated that she had been sexually assaulted, while 14 others described incidents that met the legal definition of sexual assault, including sexual touching and serious threats of sexual assault, based on the Criminal Code of Canada. In considering why these activities were not reported as violence per se, other reports in the literature indicate that these types of events are sometimes perceived as being part of the job and as such aren't necessarily perceived as violence. We will return to this topic later in this module. According to Durkatz, 30% of respondents reported receiving credible threats of violence. Half of these occurred in community settings and one-third in mental health settings. These threats were related to assessment and intervention outcomes not being accepted. Many of those assessments involved the authorization of benefits and or the provision or continuation of services. When pondering the work of OTs in such areas as home care, workers' compensation, community services, etc., one can appreciate this last scenario as being fairly common. A large Swiss study of healthcare professionals, including OTs, was conducted in 2012 in a general hospital setting. Hahn et al. Reported that 51% of respondents had experienced patient violence in the past 12 months, and that visitor violence was less frequent. Hahn also examined the characteristics of healthcare providers and the work conditions that increase the risk of experienced patient visitor violence and concluded that the younger the healthcare provider was, the more likely he or she was to report patient visitor violence. Perhaps predictably, healthcare professionals who spent larger amounts of time in direct contact with patients and visitors were at most risk of experiencing violence. Considerable research has been undertaken to understand the patient-specific circumstances under which violence is most likely to occur. Patients in healthcare settings can have stressful demands made upon them, which has the potential to increase risks that violence will erupt. Violence has been shown to occur most frequently if patients are more elderly, thus more likely to be experiencing cognitive difficulties, have cultural or language differences, are being detained and or wish to leave a facility, or lack understanding as to what is going on and are feeling insecure, afraid, or powerless. These may be exacerbated by disorientation due to their illness and or their medication. In another study, all aggressive incidents investigated on a psychiatric unit were preceded by aversive interpersonal stimulation of the patient by the nurse victim. Risk of patient or visitor initiated violence, whether it is of a physical or verbal nature, including threats, is not limited to any specific field of healthcare. Rather, was found to be present in varying degrees on medical and orthopedic units, emergency departments, mental health units and facilities, and recovery wards. Though no studies were found that examined community healthcare settings, interviews conducted for this presentation indicated that the risks are just as present and very similar in nature. Clearly, occupational therapists and their students being aware of these situations will assist in mitigating the occurrence of violence. On a more systemic level, lengthy waiting times for patients and their families can lead to fatigue and frustration, as can being confined in busy or noisy environments. Each of these situations can incite violence in patients or their concerned family members. With respect to visitor-initiated violence, more specifically, one researcher found that it occurred more frequently in emergency departments and or pediatric wards, suggesting that it may arise more frequently with patients who are deemed vulnerable, that is, those perceived to be in need of protection. The fact that occupational therapists are often in the position of authorizing benefits, such as wheelchairs, scooters, as well as services such as bathing and housekeeping, it is possible that patients and their caregivers who are stressed or frustrated at not receiving them might act out in violence. Finally, notwithstanding these types of situations, Winstanley and Whittington suggest that some forms of aggression are essentially indiscriminate and may be more simply a function of contact time with patients and visitors than any other criteria. Assessing for risk of patient-visitor violence essentially constitutes scoping one's clients and overall practice context for the characteristics and conditions listed in this and the previous slide. Patient-visitor violence can also occur due to situations that are not directly related to them, but rather due to conditions surrounding their care and to the environments in which they are receiving care. A number of working conditions have been shown to create stress and to be correlated with increased violence. For example, treatment interventions that require close physical contact with patients, such as ambulating patients, teaching transfers, and or activities of daily living. Verbal statements by healthcare professionals to patients, such as encouraging or discouraging movement, asking what is wrong, or even offering a cup of tea. Delivery of unpleasant or aversive stimuli, such as giving injections or wound care, or making patients do things they would rather not do. All have been shown to exacerbate risks of violence. Other systemic factors include a lack of privacy for patients, resulting in their sensing a violation of personal space or working with unstable or volatile persons. Long waits in clinics and emergency departments have also been identified as increasing risks of violence. In fact, in one study, 45% of respondents considered waiting times to be related to patient violence. Finally, one large and fairly recent Canadian study revealed that reports of violence were highest amongst nurses who perceived staffing and other resources to be inadequate. In fact, the less adequate resources were perceived to be, the greater the reported incidence of violence was. It was suggested by the authors of that study that if health professionals lack time to complete necessary tasks as a result of staff and resource inadequacy, patients may become agitated, thereby increasing the risk of violence. Also, at the workplace level, from a more pragmatic perspective, inadequate security measures, unrestricted movement of the public in clinics and hospitals, working alone or in small numbers, and home visiting with associated isolation have all been reported in the literature as increasing the risk of violence. As previously stated, violence perpetrated by colleagues and managers is also present in healthcare. This type of violence has been shown to lead to cynicism, discouragement, perceived powerlessness, and loss of professional efficacy, which are classic signs of burnout. This seems particularly important given evidence that healthcare professionals' ability to manage workplace violence is dependent upon having a workplace environment that unquestioningly supports their decisions and actions in the face of violence. Unfortunately, assessing for risk of psychological violence from colleagues and managers is more complex than assessing for risk of physical violence, particularly that perpetrated by patients and or visitors. However, certain antecedents have been identified. They include insufficient staffing, ambient disrespect among workers, rude and or condescending communications, and or unresolved conflict. Poor morale and increased turnover of employees are documented signs and symptoms of vertical and horizontal violence. In its Workplace Violence Handbook, Alberta Health Services provides a checklist for the assessment of workers who are believed to be presenting with warning signs of potential violent behavior. The checklist includes such hazard factors and warning signs of violence as blaming or dehumanizing others, inability to accept personal responsibility, bullying behaviors, holding a grudge, being unable to take criticism, intimidating others, breakdown of social relationships between workers, and failing to show respect. OTs, whether employees or employers, should be aware of these in their work environments. In addition to individual characteristics, there are workplace factors that have also been shown to breed horizontal and or vertical violence. These include poor relationships between health professionals as well as low supervisor and coworker support. Shields et al. Reported that nurses classified as having low supervisor support as well as low coworker support were more likely to report both physical and psychological abuse by patients. In addition, 46% of respondents reported that they were exposed to hostility or conflict from coworkers. This same study reported a similar gradient in the increase of violence with respect to the quality of nurse-physician teamwork and collaboration.